Yeah, we had that.
Oh, testing. Is the microphone on? The microphone's on? Yes. Welcome, everybody, and happy holidays. If we could just get everybody to...
microphone's not working.
Your mics aren't on.
Mics are not on?
All right, Hattie's in charge now.
This is they're on your computer. I'll lean in. Welcome, everybody, and happy holidays. It's just so great to have our group gathering once again. I was just talking with our wonderful host, Diane Littlefield from Sierra Health Foundation. Sierra Health Foundation has been kindly hosting the delivery systems and health plans and consumer advocates in this room since July 2012. What a gift. As we think about what we're grateful for this season of Thanksgiving and the holidays for so many different religious traditions. I am so grateful to every single one of you in this room. Everybody contributes here. It is a work of the heart for so many people. The devotion really matters, as we'll be hearing from Dr. Susan Ivey from UC Berkeley, who you all know by this time, later in the program. The work really matters. We have seen the rate of acute myocardial infarctions in San Diego, our first university best practices community, fall from 143 per thousand to 118 per thousand, and have that be a sustained improvement. So while we can't say that all of that improvement is due to having the medical directors of all of the delivery systems coming together every month, year after year, they started in February 2011, we know that a significant proportion of that improvement is because of that joint devotion, which is across the whole community. And so we have a third university best practices in Los Angeles. They are a rather unruly group. They don't know each other yet. It's 10 million people in LA. It's a much harder task than actually Dr. Ann Peters first came to my attention down there, where she absolutely wowed the group of medical directors there. And we'll be hearing from her in a few minutes. So before we get started, I just want to ask Diane to come up and say a few words on behalf of Sierra Health Foundation. And once again, thank you so much to our sponsors, Boehringer Ingelheim, Genentech, Novo Nordisk, Johnson & Johnson. They're all very important, but none is more important than Sierra Health Foundation. So thank you.
So hard, and she's always thankful to everyone else. And just on behalf of the Sierra Health Foundation, just want to welcome you. This is how this space is created, and we're always so pleased on behalf of the board and our president when groups such as yourself utilize the room for these kind of purposes. It's what it was designed for. So just want to wish you really happy holidays and enjoy your meeting today. And thank you, as Hattie said, for all your work and commitment to make a real difference in this region. It's really needed, and we certainly appreciate all the work that you're doing at the forefront to really make it happen and make a difference. We want to have results like that really sorted next year too, right? And so this group will help make it happen. So just thank you all. Thank you.
So I want to join Hattie and excited today to have Dr. Ann Peters. And Dr. Peters and I met quite a while ago when I was working with the Diabetes Coalition in California, and she helped us as we put together our guidelines. And very, very well published and international expert in diabetes. And so I'm thrilled to have her. And she's a professor at Keck USC School, and is doing a lot of work with the county down there and improving diabetes care for all patients. I mean, there's a huge load of diabetes in LA, as you can imagine. And we're going to be hearing a lot about the new approaches for diagnosing and treating diabetes and developing systems of care. And we'll have an opportunity to kind of also ask her a little bit about your work with the county, because I'm very interested in that as well. So please join me in welcoming Dr. Ann Peters.
All right. You're going to help me. I'm very bad at BC-based things. So let me just tell you, so first of all, I've
Can
worked
you get closer to the mic, please, so we can hear?
I will get closer to the mic when I can. I've been working in the County of Los Angeles my whole career, and so I've really been dogged at trying to make change, and make change across the population, just not in one subset of people. And what I do there is I run a program through USC that's a lot like a private practice, and it's in Beverly Hills, and I spoke to Tom Hanks this morning, who says all of you is love. He's from this neck of the woods, and he was working with another patient of mine, who came with me to the last meeting, who's a screenwriter, who told us what his experience with diabetes was all about. And in hearing him talk, I actually learned something about him that I didn't know. But the deal is I work in that community as well as in East Los Angeles, and there I run a program for underserved patients with diabetes, and we use nurses and nurse practitioners to see patients. That was set up 15 years ago as a one-center program for the most difficult patients, those patients who were falling out of primary care in terms of getting their A1Cs down. To be in that program, your A1C had to be greater than 9 in spite of being in care for at least 6 months. We took that program and we cloned it around the county, so now we have 6 of these programs. So we have 6 centers. One's at Olive View, one's in Harbor. They're all around the county. One's in High Desert, and that's sort of where we put the focus for these really difficult patients to the health system. But that's not really where care has to be for diabetes. It has to be in the primary care practice. So for the past 4 or 5 years, we've been meeting every Thursday in the evening to create a system of care throughout the county that works for all of our patients and that primarily is primary care based. And I can tell you more about it because that's not what my talk is actually about, but in the panel of patients in the county, the average A1C is 7.4%. which is actually pretty darn good given that this is an underserved population. But I can also tell you that the second anyone goes from pills to insulin is when we have the hardest time. And so it's that juncture of getting patients on insulin. Our primary care doctors are great at oral agents, but getting to insulin, whether it's basal or prandial, is where we have the biggest challenge. And then, of course, there's the other half of the patients who aren't in panels. We don't even know what their A1Cs are. They actually have relatively low costs in terms of their outpatient costs because we don't see them, but they have very high costs in terms of inpatient and emergency department care. So we're trying to get the system to be better and better. And I'm actually, in spite of the fact that you all know how hard it is to get any big system to change, I'm impressed at how LA County's been. We just last week had our second ever Diabetes Day, where we get everybody together from the whole county of the California Endowment and talk about issues and changes and how to create better diabetes care. So I think the County of Los Angeles has done a lot, and the final piece of it, of course, is the electronic medical record system called ORCID, which is a Cerner-based system, which is now throughout all of the different sites in the county. And with that, we can track everything. I love data, so I can track all the outcomes. We can tell what the issues are, and it's allowed us to make a lot of recommendations that we couldn't have before. In addition to the things I do in the county, I also create both national and international guidelines for treating diabetes. So I spend a lot of time pondering how it is best to do this. And so I'm going to share with you some of what I know and some of what's new that's actually changed the world in terms of diabetes. And just for the record, and not really to show off, this morning I got an emergency call from Larry King. And I said, Larry, what's the matter? And he said, I read in the paper that there's this magic new anti-aging drug. And I said, gee, what is it? And he said, metformin. And I said, Larry, I've had you on metformin for 20 years. He said, well, I was on glucophage. I said, it's the same thing, hon. And he said, well, is this as good as it said? Is this as good as the paper said? And I said, you're alive, aren't you? And it's an anti-aging drug. So, these are my potential conflicts of interest. I actually consult with everybody, including the FDA. The FDA has been very responsive to a lot of the input that I've been able to give them in terms of side effects as well as device safety. And I do research with Janssen and the Medtronic Foundation. So this is the algorithm, well, it's actually a guideline for treating diabetes. And this was created first in 2012 and updated in 2015. And it was written by 5 people from the US, I was one of them, and 5 people from Europe. And it basically says that we can't tell you how to treat diabetes because every setting is different, and in every setting there are different priorities. We can tell you one thing, which is that metformin is the single best choice for treating diabetes, and I can also tell you that it's good for pre-diabetes and actually really and truly may be the best anti-aging drug we have. And I think everybody over the age of 50 should take some. I guess I have my husband on it. So we are looking at metformin as the first, and then the second choice is really dependent on where you happen to work. And some of it's cost-based, some of it's evidence-based. I personally don't like causing hypoglycemia and weight gain if I can help it. And I'm going to teach you more about SGLT2 inhibitors today because they actually have a real benefit in reducing cardiovascular mortality. When you get down to the third line now, we're starting to mix everything all together. There's not a lot of good data to guide you there. And then the final step is when we add in insulin, and that becomes the most problematic step in primary care. If you blow up that bottom piece, I can tell you that what we wanted to do in the committee was to encourage people to always stay on metformin, and then if you add in basal insulin, instead of going to mealtime insulin, using a GLP-1 receptor agonist in addition to basal insulin and metformin is probably the best way to do it. And I'll talk about that more in a minute. But you get the best outcomes with the fewest episodes of hypoglycemia. Now, I'm going to talk about these drugs to teach you about them, but I'm not going to talk about cost. I know all about cost, and I can tell you how we fit these drugs into our own paradigms in the county as well as into other settings. But the first is to understand the concepts. So all of you who've eaten carbohydrate have had GLP-1 released from your intestines, and it's circulating to make you both feel full as well as to make your beta cells make insulin to go along with your food. So GLP-1 is a very important hormone, and it's either deficient in people with type 2 diabetes or there's GLP-1 resistance. So this is not normal in people with type 2 diabetes. It's also broken down really, really quickly by DPP-4. And when it's broken down and degraded, then obviously its effect is lost. So we have the first set of drugs that works with this called DPP-4 inhibitors. Sitagliptin, saxagliptin, linagliptin, and alagliptin. Anything that's a gliptin is a DPP-4 inhibitor. And what that does is it slows down the breakdown of endogenous GLP-1, levels rise, and blood sugars go down. These are great drugs for a variety of reasons. They're a pill, they have very few side effects, they're weight neutral, they have no hypoglycemia, but they have a fairly modest A1C reduction. So this is not a drug that I personally use a lot because my patients generally are sicker, need a bigger A1C reduction, and I'm not so sure that you get enough bang for the cost of these agents. I tend to use these drugs in patients where they have renal insufficiency because they can work with patients even on dialysis, and because they don't cause hypoglycemia, they can be useful in the elderly, but I spend a great deal of time getting prior authorizations for drugs like these. If they were free, it'd be one thing, but they have a high cost associated with them. So I use these pretty judiciously, and they should not take the place of metformin. If you want a better A1C reduction, you go to a GLP-1 receptor agonist. These are injectable. There's exenatide, liraglutide, albiglutide, and dulaglutide. Now, these drugs give you more A1C reduction. They actually now cause weight loss. It's not a lot of weight loss. The most weight loss I've had was like 50 pounds. There's this big window of weight loss possible. Most people lose a couple of pounds because it makes you feel fuller. It makes you feel slightly nauseous too. They don't cause hypoglycemia. They have GI side effects. They may or may not be associated with pancreatitis. So may these. I think these drugs cause a slight increased risk of pancreatitis, but it's not a huge risk, but I don't use them in patients who've had pancreatitis in the past. So if I was going to pick one of these two drugs that work on GLP-1, I would use the GLP-1 receptor agonist class because it's more effective. And I'm going to show you how much more effective in a minute. Just to get your head around it, this is the normal hormone. This is what it looks like. This is exenatide, the first one that came out, which comes from the saliva of the Gila monster. And it was found in nature. So I actually have a lot of patients who don't trust medications because they think they're poison. But if things are from nature, they like them. So just for the record, metformin comes from French lilac. So I can tell patients it's an herbal drug. And French lilac or goat's fruit. It used to make the goats die in medieval times because of the quantity and it's hepatotoxic, but don't tell your patients that. I just say metformin is from nature, which it is, just like aspirin's from willow bark. And exenatide is from the Gila monster. At any rate, exenatide is about 50% homologous to the native compound, and it has to be given either twice a day or once a day when it's mixed up with these microspheres that prolong its half-life. And then there's liraglutide, this is once a week. There's liraglutide, which is once a day, which is this GLP-1 molecule bound to albumin. Then there's albiglutide, which is 2 GLP-1 molecules bound to albumin. And there is dulaglutide. And the reason I showed you those other molecules was to show you this molecule, because this molecule is the most different. This actually is one of those sort of designer drugs where they take 2 GLP-1 peptides and a linker peptide, and they bind it to this modified IgG4-Fc domain. And what that does is it makes this an incredibly soluble, easy-to-give compound with a low immunogenic potential. And they did something really smart. They put it in a pen that doesn't require that the patient ever see a needle. And this is how, because I'm supposed to talk about how I get patients to target when it's a challenge. This is how I've actually been able to get some of my most challenging county patients to an A1C that's reasonable, because they won't use needles. I have a couple of schizophrenic patients who absolutely flip out at the sight of the needle, and this they never have to see a needle. And in fact, it's so easy that people say, I don't even think I'm giving a shot. You do feel the shot, but you take this device, you pull off the base, you stick it against the skin, you make one click, boom, and it's given, and the needle's retracted. So there's no needle. This is a once-a-week shot, and it gives you about a 1.5 to 2% A1C reduction and a 4 to 6 pound weight loss. So it's a way that I've found to overcome barriers because it doesn't require a real injection, and it's much easier for most patients to give than insulin. Again, this is an expensive designer drug, but this is one that's worth it if you have patients where you can't get their A1Cs out of the 10 to 12 range and you really want to get them better. Now this is a drug that's going to come on the market soon, and it mixes a drug, a GLP-1 receptor agonist, which is liraglutide, along with degludec. And degludec is a new long-acting insulin that's that's on the market in the United States. It's been on the market in Europe for a while. And it takes at least 2 in one pen. And so it's called iDeg-Lira. So now, each click of the pen gives the patient a little bit of insulin and a little bit of a GLP-1 receptor agonist. And this is the most powerful combination of 2 drugs that we have for treating type 2 diabetes. So you can see in this study, A1Cs of about 8.3, and the A1C on that combination falls by about 2%. This is tremendous, and this is basal insulin alone, basal liraglutide alone. So this is an incredibly effective way, and again, it's simple for the patient. It's just this little pen that they have to give, and they give both at the same time. This is a once-a-day shot, though, but patients can do it, and they're up-titrating so slowly that the GI side effects of the liraglutide tend to be mitigated. Now this, believe it or not, is a way that I am going to really help people with diabetes. And this is a little pump. It's a little bizarre device that's the size of a matchstick. And in this pump, it's a little diffusion pump, you stick whatever it is that you want to be pumped out under the skin for the next 6 to 12 months. So now, instead of having your patients give shots, do anything else once a day, once a week, or once a month, you can insert this little device once every 6 to 12 months. And so what they've stuck in this device is exenatide. And what they've shown is a tremendous benefit in those patients. Again, these are those high A1C patients that I can never get down. They've shown amazing improvements. So this looks out at 65 weeks, and somewhere in here they actually have to swap out and put another little device in. These are the patients who flunked out of the original study because their A1Cs were greater than 10. So the average A1C here was over 12. And over time, you can see how much these A1Cs fell, about 3%, and they stayed down over time. Again, another way I think that we'll be able to help patients, which is giving therapies that take away adherence. Adherence is the biggest problem that we face. Access to care, 1, adherence, 2. And I just spend my life trying to get people, whether they're rich or poor, or anyone in between, to take their medicine. This takes that away and makes it easier. So for the right patient, this is going to be very helpful. But the big news in diabetes is this: SGLT2 inhibitors. So just to review your pathophysiology, when your body is filtering glucose, you actually filter it from your glomeruli into your collecting system, and most of your glucose is resorbed in the proximal tubule by SGLT2 and a little bit by SGLT1. So basically you don't have any glucose in your urine. It's kind of a nice system. You can inhibit SGLT2, and when you do that, you're going to lose glucose in the urine. And this is how these drugs, the SGLT2 inhibitors, work. They're a diuretic for glucose. So interestingly, people think that they're going to do something to their kidneys. It's not doing something to your kidneys per se. You're actually just losing glucose. You're not resorbing it. And it turns out that data now that we have from this big trial called EMPA-REG shows that these drugs both slow progression to renal failure as well as reduce proteinuria. So these agents are actually really good for your kidneys, even though I originally thought being more glycosuria would be bad for your kidneys. So I have some patients who said to me, and it's true, is that basically what you're doing is you're shifting your renal threshold for glucose. So in a non-diabetic person, if your blood sugar is above 180, you'll be glycosuric. If you have diabetes, that threshold shifted to the right, so you actually hang on to glucose more avidly. And I think it's probably a mechanism, if you're hyperglycemic, your body wants to not lose glucose. Your body's smart, it's just dysregulated in diabetes. And then if you give an SGLT2 inhibitor, you've now shifted your threshold. So my patients on these agents, if they go out for pasta, they know it because they're going to pee that night. And in fact, they may have to pee before they leave the restaurant. So it's a very interesting phenomenon, but now you've changed the renal threshold for glucose. Everything has side effects, and I actually was one of the people that recognized that these drugs can cause ketoacidosis. And it's a longer story than I have time for, but if you want to know more about it, I can tell you about it. But in patients where these have been used off-label who have type 1 diabetes, they become, or can shift people to becoming more ketotic and going into euglycemic DKA. In most type 2s, this doesn't happen, and these are drugs for people with type 2 diabetes at the moment. So they've added this to the warning recently, but it's not something I'm particularly worried about because I think we can manage the risk. They don't cause hypoglycemia when used alone. They do increase the risk of genital mycotic infections, particularly with women, but if you start with a low dose and go up slowly, you don't tend to get into trouble. Because they're a diuretic, they can act like a diuretic in terms of volume changes. There's always hypersensitivity. They increase both LDL and HDL, and in the clinical trials data set on dapagliflozin, there was a concern about bladder cancer, which I think will be taken off in the newest labels. You can't use these drugs in patients with renal impairment. So basically, if the eGFR is less than 45, you can't use them, although in the EMPRO-REG study, which I'm going to talk about, they actually used epagliflozin in patients down to an eGFR of 30. But you need to watch that when using these agents. But this is the real headline, and this is the most exciting diabetes news that I've seen in the past 10 years. We have been struggling to prove that lowering blood sugars lowers cardiovascular disease risk. And yes, it does if you start very early, say in the EKPDS study, and wait for 10 to 15 years. But it's really been the statins, the blood pressure control, everything else that's really helped us. And if you look at this forest plot, which is a meta-analysis looking at data, yes, you see some potential benefit in terms of glucose lowering and myocardial infarction risk, but it's not shown to be an improvement in overall mortality. And even though we prevent blindness, kidney failure, and nerve damage, which, trust me, matters to patients, this holy grail of reducing myocardial infarction risk has not been found. Not found until this study. This is the EMPRO-REG trial, the results of which were released at the EASD meetings in Stockholm this September, which was a cardiovascular outcomes trial looking at empagliflozin versus placebo in terms of cardiovascular morbidity and mortality. It was a randomized trial, and it had 3 arms: placebo, EMPA 10 milligrams, and EMPA 25 milligrams. And you actually don't need to worry about the doses because it turns out that those 2 doses had equivalent benefit in the trial. So empagliflozin any is good for you. It was, the study ended after about 2.5 years because that's when they got enough events. So it was an event-driven trial. To be in the trial, you had to have type 2 diabetes, you had to be reasonably heavy and have an elevated A1C, but you had to have advanced established cardiovascular disease. So these are all secondary prevention patients. Everyone had a prior MI, a stroke, or peripheral arterial disease. So these are people who are at the highest risk for having a cardiovascular disease event. And the primary outcome I'll talk about is the 3-point MACE, which is time to first occurrence of cardiovascular death, non-fatal MI, or non-fatal stroke. These patients were in their 60s. They were primarily male, which is important, so about 70% were male. They were from all over the world, about 20% from the United States, but there was no difference depending on where you came from. Average A1C was 8, and a lot of these people, over half, had diabetes for 10 or more years, so long-duration disease, sicker patients. These patients were about half on insulin, and the investigators could use any medications they wanted other than using an SGLT2 inhibitor. They're heavy, but not as heavy as a US population. Their average BMI is 30. They were well treated. Their blood pressures were well controlled, on average about 135 over 76. And they had an LDL that was below 100, and about a quarter of them had a GFR below 60. These people had primarily had a history of MI, but you can see they had a lot of different cardiovascular comorbidities, and about 10% had cardiac failure. They were treated well, so they were on ACE inhibitors and ARBs, they were on statins, and they were on aspirin. So this is a therapy on top of pretty much maximal cardiovascular risk reduction. A1Cs get better. but not a lot better. This isn't a huge reduction in A1C. A1C fell to about 7.5% and remains lower. And again, the two doses is exactly the same in terms of all the outcomes for this study. And about the first 12 weeks, you get the biggest fall. But this is not an A1C lowering event here. You get much different findings with this study. People lose some weight, and that weight stays off. People's systolic blood pressure gets a lot better, and it stays better. And the 3-point MACE, and this is the first time we've ever seen this with a diabetes drug, is now statistically significantly better if you compare placebo to empagliflozin. And this is about a 14% reduction here in MACE. And amazingly, you'll see this again and again, it starts before 6 months. So the separation in these curves starts right away because this is a diuretic for sugar. It's having some immediate hemodynamic benefit in addition to everything else these guys are on at lowering this risk. If you look at cardiovascular death, huge reduction. And the thing is, this is a 38% reduction in mortality compared to, or cardiovascular death, I'll show you mortality data, compared to everything else. And so I put my patients on this, and look at the difference. It starts right away. And I say, this drug is so great, it's going to help reduce your mortality, it's amazing. And they say to me, well, what will I feel? I said, alive. That's what you're going to feel. It reduces your risk of death. But it's like a statin. It's like anything else. This drug isn't going to make you feel better, but I know in my heart of hearts that I'm finally using a diabetes drug that's lowering the risk of cardiovascular death. To me, that's a triumph. Nothing personal, but me and my cardiology friends, I like to keep my patients away from them. This just looked at the two drugs together, the two doses, and again, there wasn't really much of a difference, so you can use 10 or 25. Now, not everything's perfect, so look at this forest plot. Cardiovascular death, MACE, significant, but non-fatal stroke actually tips slightly in the wrong way, which is weird because blood pressure is better. You'd think it would go the other way. But if you analyze the people with the strokes, this is the on-treatment group, or this is the all-comers, and this is the on-treatment group. On treatment, there was no change. But when you actually look at who had the strokes, it was 30 days, within 30 days after starting the drug. After stopping the drug. So it seems to be, I think, that probably what happened, and they're looking into this, is that when you stop a drug that lowers blood pressure and there's no protocol for restarting a drug to help with your blood pressure, that their blood pressures probably go up like it would if you stopped a diuretic because the strokes happen off the drug, not on the drug. But that data is being looked at. At any rate, on treatment analysis, there was no change in stroke. If you look at hospitalization for heart failure, you want to reduce costs related to hospitalization for heart failure in these high-risk patients, give them this drug. To me, it looks like the second they get the drug, they stop needing to be hospitalized for heart failure. So again, this is on top of everything else they're on, a very significant reduction. And there's been more data now about hospitalization for heart failure in this trial. Very significant reduction. This looks at all-cause mortality, which was reduced by 32%. So we finally have these diabetes drugs that can make a real difference in these very high-risk people. And these drugs work. The overall A1C reduction, as I said, wasn't so great here, although in individual patients it can be bigger. You might say this looks a lot like a statin. So if you think about it, in the studies that have